We'll get started now. So we have a lot more actually to go still this afternoon, starting with our next invited speaker, who I'm really delighted to introduce, Dr. Keith Yeates, who is professor and head of the Department of Psychology at the University of Calgary. This isn't Keith's first rodeo here with us at the Canadian Concussion Center conference. We're really happy to have him back. Keith is the Ronald and Irene Ward Chair in Pediatric Brain Injury, professor and head of the Department of Psychology, as I just mentioned, and adjunct professor of Pediatrics and Clinical Neurosciences at the University of Calgary in Alberta, Canada. He is the inaugural chair of the Canadian Concussion Network. He has a 30-year track record of funded research focusing on the outcomes of childhood brain disorders, especially traumatic brain injury. You've heard others referring to him and his work earlier today. A recent published bibliometric analysis indicated that he has authored more of the top 100 cited papers in pediatric TBI than any other researcher. And he has been ranked as one of the top 10 most influential neuropsychologists in North America over the past 50 years. So Keith, please go ahead and take it away. Keith's topic is concussion in children.
Thanks, Robin. I want to thank you and Charles for inviting me to be part of the symposium today. I was looking forward to it. I'm sorry we couldn't do it in person. But it is a beautiful day in Alberta, as I shared with the audience earlier, and I'll get outside later and enjoy that. I'm going to share my slides, try not to make the rookie mistake I made yesterday or last night. Hopefully you can see it. It says that you can, so I'll go ahead and get started. I just want to start just by disclosing that I have grants and research support currently from CIHR. I do a very small amount of medical legal work. I have a disappointingly small amount of book royalties, and I get an editorial stipend from the American Psychological Association for the journal I edit. I'm just going to ask as I go through the talk, there will be some unpublished data in here, so I'd appreciate it if you didn't take pictures or screenshots of the presentation. The website for the symposium does have a copy of the presentation with 4 slides removed that are unpublished data. If you're really interested in that data particularly, you're welcome to get in touch with me and I will share it individually. I just don't want it distributed. Thank you. So preaching to the choir here, concussion is a significant public health burden in children. Many children and adolescents sustain these injuries each year. Just hospital visits alone probably account for 750,000 in the United States each year, most of which are mild, more likely in the millions. Nice work done by Don Comstock and Fred Rivara and their group, estimated 1 to 2 million sport-related concussions annually in the United States. Data in Canada is a little bit harder to come by, but based on epidemiologic work by several groups, including Mark Bailey's, ours, and Roger Zemek's, as well as by extrapolation from the States, would estimate we probably have 150 to 200,000 concussions annually in youth in Canada. Of course, concussion has been identified as a target for research by all the leading healthcare and health funding agencies. Been a hot topic in the media until the pandemic began. Before the pandemic, it was rare that you go a week without hearing a story about second impact syndrome or post-concussive symptoms or chronic traumatic encephalopathy. The scientific literature has exploded, where we averaged 100 publications a year up to about 2010. We now have well over 1,000 a year with concussion. So, it's an important problem. And as I've said for almost 25 years now, the point is that even if a small proportion have persistent negative outcomes, concussion still is a major public health burden simply because of its sheer ubiquity. So what about the outcomes of concussion in kids? The so-called holy triad traditionally has been symptoms, balance, which we can measure on the sideline or in an acute care setting with measures like the BESS, and tests of cognitive ability, often computerized. In more recent years, the newer outcomes that have come to be of interest include vestibular and oculomotor measures, as we realize that the disturbance in the vestibular and oculomotor system are associated with certain specific symptoms like dizziness. We've seen increasing interest in cardiovascular and cerebrovascular measures, especially as we've come to recognize the role that exercise might play in recovery from concussion. And of course, there's been an explosion of work in the area of neuroimaging and fluid biomarkers as we try to find biomarkers that can be used both to detect concussion, to track its recovery over time, and to be used as a proxy for treatment outcomes as we begin to develop more clinical trials. Today, I'll probably focus more on symptoms and cognitive ability and neuroimaging than any other areas, but they're all worthy of our attention. So just how often do persistent post-concussive symptoms occur in kids? My graduate student, Leah Chadwick, and another graduate student here, Manu Sharma, along with several faculty and me, did a systematic review and meta-analysis that's in press now in the Journal of Pediatrics. We found 13 studies with a little over 5,000 children or youth with concussion and a much larger group of comparisons that reported rates of persistent post-concussive symptoms. And the overall estimate was that 35% of kids demonstrate persistent post-concussive symptoms. Those rates in a meta-regression were higher for older children, for female children, higher for those presenting at clinics, which of course is a problem with selection bias. The rates are not quite so high when you use inception cohorts. But nonetheless, clearly a significant minority of children do have persistent symptoms. Now, one point I would make, and this is based on a different paper that Andy Meyer headed up that I was part of, is that how we measure or how we classify persistent post-concussive symptoms makes a big difference. Traditionally, most definitions have relied on sort of a simple count of the number of new or worse symptoms over time. In fact, the entire systematic review is based on those sorts of studies, but there are indications that that likely overestimates the number of kids, because if you use kids with other types of injuries, they show high rates of persistent symptoms as well, often 20% or more. But when you use a more statistically robust approach, like standardized measures or reliable change, you get a somewhat different picture with lower rates of persistent symptoms in kids with with concussion, probably more like 15 to 20%. So the 35% estimate that we got in the systematic review is likely a little bit higher than it would be if we studied an inception cohort and we used more robust methods of identifying persistent symptoms. Nonetheless, once again, although the majority of kids recover, the research suggests there is a significant minority that have persistent problems lasting at least a month or longer. To talk a little bit more about outcomes, I want to just share with you some data from our mild injury outcome study. This was a study funded by NIH that took place from about 2013 to about 2018. Now, we recruited kids at 2 sites in Ohio. That's where I came from when I left the United States and came to Canada 8 years ago. We had imaging analysis sites at BYU and the University of Utah, and I want to acknowledge Aaron Bigler, who has been one of my long-term collaborators and mentors for many years. I know he spoke earlier today, and we didn't get a chance to compare notes, so I'm hoping I don't repeat too much of what he had to say. We had a great team of investigators. One of the other sites was headed up by my long-term collaborator, Gary Taylor, another neuropsychologist. So this is a prospective cohort study with 8 to 16-year-old kids presenting to the emergency department. Our goal was to recruit 300 kids, 200 with mild TBI and 100 with orthopedic injury. We administered common diagnostic tools, so measures of acute signs and symptoms, a brief but standardized measure of mental status, and the BESS, or measure of balance, in the emergency department. We brought the kids back for neuropsychological testing and MRI at 1 to 2 weeks post-injury, and we had follow-up visits that included that visit at around 10 days, and then secondary visits at 3 months and 6 months. We obtained retrospective ratings of premorbid functioning shortly after the injury, and our focus was on post-concussive symptoms and functional disability. And we're really interested in this particular study on how to predict outcomes from common diagnostic tools. Our inclusion criteria are based on the WHO criteria for mild TBI. So the child had to have one of these 3 things, at least one of these 3, an observed loss of consciousness for less than 30 minutes, a Glasgow Coma Scale score of 13 or 14, or at least 2 symptoms of concussion as reported by medical staff in the emergency department. And that would include things like persistent post-traumatic amnesia, transient neurologic deficits, vomiting, nausea, headache, and the other types of symptoms that are fairly common acutely in the emergency department. So we wound up consenting just shy of 200 kids with mild TBI and a little over 100 of kids with orthopedic injury. Most of the kids came back for their post-acute assessment and then went on to be seen again at 3 and 6 months, although we did have some attrition. And it's interesting when you look at the rates of attrition. We have a paper we're working on right now where we actually examine who consented versus who didn't, because we were allowed to collect a very small amount of information on the children who didn't consent, and then who comes back for visits. And it's very interesting that it's largely driven by social determinants of health. It's related to socioeconomic status and race, where actually our non-white families were more likely to consent, but less likely to return at post-acute. And that's correlated with other measures of SES. So interesting patterns there. But it turns out that the patients who came in for post-acute were very similar overall to those who either didn't consent or consented but didn't come back. So in fact, despite the attrition, we wound up with relatively, I think, bias in the sample, little bias in the sample as a consequence of attrition. About 2/3 of the kids were male. That's typical, of course, for these sorts of injuries. This is an unusual sample in some respects in that actually the majority of kids were non-white. But it was about 50-50. Median family income, age at injury, days to post-acute assessment were all comparable between the two groups. IQ was smack dab average, as was their retrospective ratings of behavioral adjustment on the VASC. So this is a pretty well matched sample, and we do choose to use kids with orthopedic injuries as our comparison because they are well equated for background characteristics, also including risk of injury. We know that kids who are healthy controls and not with orthopedic injury actually tend not to have those same background risk factors. The kids with orthopedic injury, of course, also have the experience of having had to go to the hospital for a traumatic injury. And it turns out, although I don't have time to go into it today, when you do baseline MRI on kids with mild TBI and orthopedic injury, they are both different from healthy controls. It's been shown in several papers now, including ones from our group, whereas they're pretty similar to each other. So there's something different about kids who get injured, and healthy controls could potentially be misleading. This is their acute signs and symptoms right in the emergency department. Not surprisingly, almost all of them report headache. About 2/3 complain of dizziness, about half of nausea, and about half have other mental status changes. One thing I'll note is only 11% of the sample in the kids with mild TBI had a GCS less than 15, and only 6% had trauma-related MRI abnormalities. It's interesting just to note that that's a very low rate, of course, with a 3T magnet and the most current imaging sequences we had available to us at the time. But what's interesting is it's about only 1/3 the rate of a study we did preceding this one, our very first large-scale study of mild TBI in kids. And what's happened is the kinds of kids who come to the emergency department have changed over the years and are actually less severely injured than what used to present for mild TBI. And I think that's because of increased awareness. Parents are more likely to bring their kids for medical attention for concussion as opposed to a little bit more severe injury. Just to start off talking about outcomes, I enjoy presenting this paper because this paper was authored by my daughter, who is now doing her residency in pediatrics at Nationwide Children's Hospital back in Columbus. This was for her master's of public health during her medical degree. But what she was interested in was sex differences, because there's still a lot of questions about whether or not there are sex differences in outcomes from concussion. And a lot of the literature has tended not to use control groups. So we often find differences between girls and boys with concussion, but we don't know if those differences, in fact, are specific to concussion or extend across the population in general. And we looked in this particular study, we looked at symptoms and cognitive outcomes and balance, and found, in fact, their sex did not moderate the outcomes of concussion. While there were some sex differences in symptom reporting, that was characteristic of both the kids with mild TBI and the kids with orthopedic injury. So in this particular study, we didn't find any evidence that sex actually moderated the effects of concussion. Now, the thing that I'll draw your attention to is that all of these are essentially over time graphs of different types of symptoms, so either somatic symptoms or cognitive symptoms as reported either by the child or by the parent. And they all follow a very characteristic trajectory that I'll get back to again in a little while. But just note that what we see here is that the mild TBI group consistently has higher levels of symptoms than the kids with orthopedic injury out to about 4 weeks post-injury. Very characteristic of a lot of the literature that suggests the majority of recovery, the majority of children do recover by about 4 weeks post-injury, although, as we'll see, that hides some heterogeneity in outcome. We've been also using our data to look more specifically at certain types of symptoms, particularly headache. Headache is the most common symptom reported after concussion in children and adolescents, yet there's surprisingly little detailed data about the nature of the headache after concussion. So we had used a fairly detailed headache questionnaire in this study that had been validated previously and looked at headache frequency, severity, duration, type, whether migrainous or tension type. And what we found was that headache, not surprisingly, was more common after mild TBI than orthopedic injury out to 3 months post-injury, especially among kids without pre-injury headache. So this graph here shows the mild TBI group and the orthopedic injury group divided into whether or not they had a history of premorbid headache. What you see in the two lighter lines here are the mild TBI kids of both types have higher rates of headache than both types of kids with orthopedic injury post-acutely. By the time we get to 3 months, the kids in the orthopedic injury who had premorbid headache look pretty much like the kids with mild TBI who had premorbid headache. But when we focus on the youth who didn't have premorbid headache, you still see a significant difference at 3 months in terms of headache probability. Over half of the kids with mild TBI who didn't have a history of premorbid headache had post-injury headache, post-traumatic headache out to 3 months, whereas that rate was only about 20% in the orthopedically injured kids. The kids with mild TBI also reported more frequent headache at the post-acute time period. It was no longer significant at 3 months or 6 months. There were no differences in headache severity or headache duration as reported by the youth, nor were there a difference in the headache type. But I think in this case, there was a trend to see migrainous headache as being somewhat more common in mild TBI, and it may have been a lack of statistical power, even with nearly 300 kids. By the time you start breaking it down into multiple categories, the statistical power tends to get fairly low. We've also looked at cognition using the NIH toolbox. For those of you who aren't familiar with this, it's a computerized test battery developed by NIH to cover the ranges of 3 to 83. The intent was to use fairly well-established measures largely from neuropsychology to test different aspects of fluid and crystallized cognition. Fluid cognition being executive functions, attention, processing speed, episodic memory, and crystallized cognition being more traditional measures of cognitive ability in terms of vocabulary and reading. My graduate student, Leah, who I've already mentioned, published a nice study last year looking at cognitive outcomes using the MEOS data. And to put it quite simply, we see significant differences on the measures of fluid cognition that are actually still significant at 3 months, but no significant difference at all in the measures of crystallized cognition. It was interesting that the differences between the kids with mild TBI and orthopedic injury were largely a reflection of reaction time, but reaction time on complex measures of executive function. What it seems to be is that it's the combination of speed and complexity that's problematic for kids with concussion or mild TBI. And we saw differences out to 3 months, which contradicts the prevailing wisdom, which is that we only see cognitive differences for a matter of a week or so. But I think that may have something to do with the tests we use. And many of those, the existing literature based on traditional paper pencil tests from neuropsychology that don't provide very exact measures of reaction time, whereas the advantage of computerized tests is that we can measure reaction time very closely and begin to pick up these more subtle differences in cognition. So what about prognosis? We know that there's a certain percentage of kids who are going to continue to have persistent problems after concussion. What predicts who has those problems? Traditionally, this argument or debate has been framed in terms of physiogenesis versus psychogenesis. Leishman's classic paper from 1988 really set this forward. And then Noah Silverberg and Grant Iverson wrote a nice sort of update of that concept back in 2011 in neurorehabilitation. Essentially, it boils down to the argument of our persistent post-concussive symptoms and other problems that persist after concussion really linked to the underlying injury, i.e. to physiogenesis, or are they largely psychological sort of artifacts or caused by psychological issues that really have nothing to do with the underlying injury? Almost 20 years ago, Gary Taylor and I published a paper setting out the basis for our very first large-scale study, where we put forward a biopsychosocial framework and argued that it's not either or, it's not psychogenesis or physiogenesis, but likely to be a combination of both in different degrees for different patients. The notion was that post-concussive symptoms and functional outcomes associated with concussion would be partly a reflection of the injury itself, but also a reflection of what the child and the family brought to the injury and how the child and the family reacted to the injury. And that it would be this complex interplay of the injury, the child, and the family, and the parenting and family environment that really would co-determine the occurrence of post-concussive symptoms and related functional outcomes. Recently, I was fortunate enough to be part of the 5P study, and this is where we begin to see really important evidence of this biopsychosocial framework. This is a study headed up by Roger Zemek at C.E.T.S in Ottawa, a prospective cohort study of over 3,000 patients across 9 emergency departments here in Canada. They looked at multiple potential predictors, and the goal was to develop an actual prediction rule that could be used in the emergency department to predict persistent post-concussive symptoms at 4 weeks. There were other outcomes that included quality of life, neuropsychological outcomes, psychosocial adjustment, but I'm going to focus on persistent post-concussive symptoms today. The study resulted in a really landmark publication, I think, in 2016 in JAMA, where the clinical risk rule was derived and cross-validated in a separate cohort from the same emergency departments. And I'll just note that it's a fairly simple measure, and it combines demographics like age and sex, where girls and older children are at higher risk, history of concussion and whether or not it had symptoms that lasted longer than a week, so prior concussion history, migraine history, so another aspect of medical history with presence of migraine history being associated with higher risk. Then there were 2 directed physical exam questions, one of whether or not the child was thought to be answering questions slowly, probably a reflection of mental status issues, and then balance problems on the best. And then finally, 3 symptoms: headache, sensitivity to noise, and fatigue. These can be combined in a fairly easy way, add up to a score of 0 to 12. And it turns out that risk score is significantly better at predicting persistent post-concussive symptoms than physicians alone, with a area under the curve of around 0.7, which is good, certainly a lot better than what the physicians are able to do on their own, but definitely also leaves room for improvement. Just to see how it works, low-risk kids had a post-test probability of having persistent symptoms about 15%, as opposed to high-risk kids whose score is 9 to 12 had a 60% probability of having persistent symptoms at 4 weeks. So this is a really useful pragmatic tool, but also tells us a bit about concussion, because it tells us that the kids that are injured make a difference. Are they girls? Are they boys? Are they older? Are they younger? Tells us that their history, that what they come in with, whether they have a history of concussion or migraine, tells us that the current exam and the severity of the injury likely also plays a role. One of the things that a large study like the 5P study allows us to do is to examine trajectories of recovery over time as stratified by age and sex. This is a nice paper that Andrea-Anne Ledoux, who was Roger's postdoc and is now on faculty at C.E.T.S or at the University of Ottawa, looked basically at sort of growth curves in reverse. These are symptom curves over time as a function of sex and age. Sorry. That wasn't supposed to happen. There we go. It shows that there's that expected recovery out to about 4 weeks, although recovery takes longer in adolescents than it does in 5 to 7-year-olds, and a bit longer in females than in males, and a bit longer, as I said, in the older ages. Even within the age brackets, there was some age differentiation. For example, the older kids in the 13 to 18 bracket took a little bit longer than younger kids in that bracket. So we see this sort of general trend, the symptom, the trajectory that I mentioned before, where we see rapid recovery over about the first 4 weeks, maybe a little bit more gradual recovery beyond that out to 8 or 12 weeks. So we can use this as a way of just deciding whether a child is showing an atypical type of recovery trajectory. Of course, these are based on group averages, and they do tend to hide a certain amount of heterogeneity. One form of heterogeneity that they hide is the kinds of symptoms that children are reporting. So this is a nice paper, again, based on the 5P data set that we have just recently had accepted for publication in the British Journal of Sports Medicine. And I'll lead you through this just to try to keep it simple. We took a large array of symptoms and clustered them both by symptom as well as by patient. And what we saw was one cluster of symptoms that tended to be vestibular in nature, so problems with balance, dizziness, vision, and nausea. We saw a second cluster of symptoms that combine headache-like symptoms or migraine-like symptoms, or headache, sensitivity to noise, and sensitivity to light. We saw a cluster of symptoms having to do with emotional issues of sadness, nervousness, and irritability. A cluster of symptoms that are more cognitive in nature, difficulty concentrating and remembering, and then fatigue. Fatigue is interesting because it's the most common symptom that occurs in concert with other symptoms, and obviously is a major source of complaint. When we clustered individuals, what we saw is there's a big cluster that have relatively few symptoms, and that in fact is the majority of the sample. We have a cluster of individuals that are sort of mildly symptomatic, mainly fatigue and some cognitive difficulties. Then we see a cluster of individuals who have more moderate symptoms, sometimes having to do with the headache cluster, sometimes having to do with the vestibular cluster, and some cognitive difficulties, again with fatigue. And then finally, we have two clusters of relatively severe symptoms, one that's largely characterized by difficulties with mood and cognition and fatigue, and then a cluster that are found across the board. So we see these heterogeneity in the nature of the symptoms that tend to go together and the people who demonstrate those symptoms. And so simply trying to describe trajectories tends to miss a bit of this important heterogeneity because, of course, the kinds of symptoms that a child displays may have significant implications for treatment. Another way of looking at heterogeneity in symptom trajectories is actually subtype individuals based on their trajectories. We did a study a number of years ago now where we subtyped kids' trajectories across the first year post-injury of kids with orthopedic injury and mild traumatic brain injury. We found 4 symptom trajectories. This is based on latent class analyses in essence. We found one trajectory with high acute symptoms that did not fully resolve by 1 year. We found a different trajectory with relatively high acute symptoms that resolved by about 3 months. We found one trajectory with low levels of symptoms, but they continued over time. And then we had a trajectory with very few symptoms that pretty much resolved in the first 30 days. Then we looked at how those were related to the groups that they belonged in. We subdivided the children with mild TBI into those with high risk or low risk based on indicators like loss of consciousness, GCS less than 15, intracranial abnormalities, and MRI. A couple of points to make here is that the majority of kids in all the groups tended to fall into this trajectory with relatively few symptoms. So even among the children with mild TBI who were high risk, about 60% of them didn't show significant symptom onset following their injury. But in the kids with high risk, about 35% of them fell into one of these two trajectories with high acute levels of symptoms, and a good 15 to 20% fell in this trajectory that has high levels of symptoms and does not resolve by 1 year. In contrast, only about 5% of the orthopedic kids fell into either one of these sort of higher levels of symptoms post-injury groups. And in the low-risk group of mild TBI, it was about 15% who fell into these two. So we do see heterogeneity in the trajectory of symptoms, and there is a significant subgroup of kids who show persistent symptoms even as long as a year post-injury. More recently, since I came to Canada, we did a larger study of the outcomes of concussion in kids, the Advancing Concussion Assessment in Pediatrics study, or ACAP, as it's fondly called. This involved 5 sites from the PERC network, the Pediatric Emergency Research Canada network, Alberta Children's Hospital, CHEO, BC Children's, Saint-Justine in Montreal, and Stollery in Edmonton. This was a prospective concurrent cohort study as well. We recruited kids from the emergency departments and followed them for 6 months. They were 8 to 17 years of age. We consented almost 1,000 children, about 644 in the mild TBI group and 339 in the orthopedic injury group. We had about 800 kids who came back for their post-acute assessment. And this provides us with enough statistical power to really look for complex interactions between neurobiological and psychosocial risk factors. We are still mining this data, but the data is it's a very large data set that includes predictive variables that are neurobiologic in nature. So we have genetic data, we have imaging data, we have measures of injury and severity. We have a lot of psychosocial data. So we have data on the kids' pre-injury, psychological functioning. We have measures of the family environment, life events. We have measures of motivation. We have a lot of different predictive variables, and we have a variety of outcomes. So this is data that we're just now really beginning to explore. But I just want to share one interesting analysis, or set of analyses that we've been doing recently. And again, this is looking at subtyping of symptom trajectories. What we did is we took the kids with mild TBI who reported their symptoms on a weekly basis during the course of the study. And we used each weekly rating and classified each of those ratings as showing or not showing reliable change based on the orthopedically injured kids. So these are whether or not their symptoms increased from estimated premorbid levels at a level higher than would be expected to occur relative to the kids with orthopedic injury. And no matter how we do this, whether we do this based on parent ratings or child ratings, and whether we do it based on ratings of somatic symptoms or cognitive symptoms, we tend to get 4 fairly similar trajectories. So there's a trajectory of kids with sort of chronic symptoms here in the red. And this is actually up here, a spaghetti plot showing all the individual kids in this particular group. And what you see is that they're red pretty much across the board, and red is reliable change. So red is that they are symptomatic as defined by reliable change at the given time. You see a few blips of yellow here and there where the kids are not symptomatic, but this is pretty much a chronically symptomatic group. We then have this group here that starts just as high in terms of the probability of being symptomatic, but drops fairly rapidly, and by about 8 weeks has recovered pretty much. That group we call the slow recovery group, is illustrated here in this spaghetti plot. And you see that most of the kids are symptomatic for a period of 4 to 8 weeks or so, and then are asymptomatic for most of the time after that. We then have an interesting group that we started calling the slowly worsening group. But then when we looked at their spaghetti plot, I think the better name might be either relapse and remit or late onset, because we see a group of kids up here toward the top that tend to come and go in terms of whether or not they're symptomatic. And then there are a group of kids here along the bottom that tend not to be symptomatic for some time and then later become intermittently symptomatic. It's a very interesting group that warrants closer attention. These seem to be kids whose symptom status varies across time. And then finally, we have this group here in the green that start out with some probability of being symptomatic, but pretty rapidly are no longer symptomatic by 4 weeks post-injury. And you can see that here, that it's mostly yellow because most of these kids have at best a short period of being symptomatic and then are asymptomatic thereafter. We've begun to look at how these clusters differ, and I'm just going to point out a couple of things here. These clusters, which in this case happen to be defined by parent ratings of somatic symptoms, differ by age. So the kids who are chronically symptomatic and the kids who show slow recovery tend to be a bit older than the kids in the rapid recovery group. They differ by sex, interestingly, and this is where we are seeing some evidence that there may be sex differences in outcome in this particular study, where the chronically symptomatic kids are nearly 2/3 female, whereas the rapid recovery group is nearly 2/3 male. So major differences there in sex difference. in sex. We see a little bit of difference in race in that, interestingly, this slow recovery group, and this is seen in some of our other symptom measures, is actually more predominantly white. And it may be something to do with socioeconomic status or the likelihood of symptom reporting. We definitely see differences in their 5P risk score. If you remember the 5P score that I went over, risk is much higher, particularly in the slow recovery group, but higher in the chronically symptomatic and intermittently symptomatic groups. There's some indication of a higher rate of loss of consciousness in the chronically symptomatic, and most noticeably, they have very different levels of acute symptoms in the emergency department. So that the level of symptomatology seen in the emergency department is an indicator of what kind of trajectory they're going to follow. What I think this signals is that there are differences that are both, again, psychosocial as well as neurobiologic. So there are indicators that the severity of the injury makes a difference, but the environment that the child comes from in terms of socioeconomic status, as well as their own background in terms of age and sex, makes a difference. So that what we get the sense of is that the membership in these categories and these trajectories is a complex function of both biologic and psychosocial factors. What about the brain? I'm just going to mention that when we looked at the data in MEOS, we did find some interesting differences in cortical thickness in certain areas of the brain between the children with mild TBI and OI. Interestingly, it was thicker in the group with mild TBI, and that may be some reflection of delayed maturation, or it could be something to do with edema, because these are post-acute images. We also found, though, that there were no group differences on measures of DTI acutely, post-acutely, but the DTI was related to symptomatology. We've begun to publish studies out of the ACAP data where we generally don't find overall group differences despite our sample size, which gives us plenty of power to find them if they're there. But where we do find differences is as a function of symptom status. Interestingly, the kids with mild TBI who don't show persistent symptoms sometimes show, in some sense, healthier brains than the orthopedically injured kids. So, for example, they have higher FA in some regions than the orthopedically injured kids. Conversely, the kids with persistent symptoms of mild TBI tend to show evidence of perhaps less healthy brains, more microstructural alteration, so that they tend to show higher degrees of, say, general diffusivity or mean diffusivity. So we are finding differences, but the interesting thing what's tending to come out in ACAP is the differences actually become more apparent with time. They're less apparent post-acutely in some cases than they are at 3 or 6 months. We've looked at some newer imaging modalities. This is Nick Sater, who's now a neurosurgery resident and did his master's thesis with me, where he looked at quantitative susceptibility mapping and found some interesting trends where QSM measures differentiated post-concussive symptoms, kids with post-concussive symptoms, over and above the 5P rule. So one of the, I think, the big challenges for the field is to find ways to build on the 5P rule, build on that 0.7 area under the curve to even do a better job being able to prognosticate which kids are going to have persistent symptoms. The injury isn't everything. This is a nice paper done by one of my former postdocs, who's now on faculty at Nationwide Children's Hospital, where we compared injury and non-injury factors, predictors of post-concussive symptoms. And the bottom line was that demographics and premorbid child and family factors accounted for more variance in symptom outcomes than injury characteristics did. The injury factors did play a role, particularly post-acutely, but even at that point, other factors made more of a difference. One of the things that makes a difference is pre-injury symptoms. So there's a nice paper that Andrienne did, again, based on the 5P study, showing that pre-injury symptoms are a predictor of the likelihood of new onset symptoms. So we're, again, it's sort of a case of the rich get richer and the poor get poorer. Kids who have really few symptoms coming into one of these injuries are at less risk of having new and worse symptoms than kids who have higher levels of pre-injury symptoms. Psychological resilience likely makes a difference in symptom expression after the injury. This is work by my former doctoral student, Christiane Lalabata-Durish, who's just finishing up her postdoc at C.E.T.S. She's published a number of papers showing that resilience makes a difference. It turns out resilience is not likely a moderator of the outcome. Resilience is good for all kids, but does reduce the number of symptoms seen in kids with concussion. We've also been interested in screen time because of the long standing sort of belief in the absence of any empirical data that screen time is bad for kids after concussion. There was a nice clinical trial published by Rebecca Mannix and her group recently in JAMA Pediatrics that did show a significant difference between kids who were instructed to be abstinent from screen time as those who were permitted to have screen time, although we'll just highlight that even the abstinent group had screen time. It was just a low amount, where they did recover somewhat faster in the first week. But we used all the data in ACAP to take a much broader look at screen time and found that it might not be that simple, and that while it may make sense to reduce screen time in the first few days post-injury, when we look at the amount of screen time kids have over the first week post-injury, we actually found a sort of Goldilocks phenomena. And you can see it probably best in this particular set of graphs, where the biggest differences between kids in the orthopedically injured group versus the mild TBI group and symptoms were not at the highest levels of screen time, but in fact were at the lowest levels of screen time and the higher levels of screen time. So that we see sort of a Goldilocks phenomena where a moderate amount of screen time actually has less pernicious effects than too little or too much. Too little probably reflects social isolation and perhaps more symptoms. Too much may in fact retard recovery, in part because it may reduce physical activity. So the bottom line is we need to seek simplicity, but distrust it. Concussion does result in persistent symptoms in some kids, but lots of risk modifiers. In the interest of time, I'm going to fly through the next section. I'm just going to say concussions can be prevented. Most of these injuries are preventable. There's no such things as accidents, as my colleague Carolyn Emery would say. Particularly in sport, changes in policy, rules, equipment, and training can make a very big difference. That's been demonstrated very dramatically in hockey with the elimination of body checking and the change in Hockey Canada's body checking policy that was driven by the research that Carolyn did, showed a reduction of over 4,800 concussions in Canada annually. We're beginning to get a better idea about treatment of concussion, despite the fact that until probably the last 5 to 10 years, there was really a paucity of evidence, and most of the recommendations were based on expert opinion. But we begin to have trials of exercise. This is a trial that Andrea Ann led at CHEO, showing that early exercise onset is associated with somewhat faster recovery. There have been trials of melatonin that Karen Barlow, who was formerly at Alberta Children's Hospital, led, where it didn't result in reduction in symptoms. It did improve sleep. We've shown that sleep problems after concussion can be improved through cognitive behavioral therapy. And Fred Rivar and his group have shown that collaborative care that combines psychosocial support with pharmacotherapy and psychiatric support can really improve the outcomes of concussion. So a couple of quick take-home messages. Concussion diagnoses have increased dramatically in recent years. The numbers keep going up, and that's largely, I think, because of increased awareness. Outcomes in kids are variable within kids in terms of the kinds of symptoms they show, and across children in terms of who recovers versus who doesn't. Most kids recover within 4 to 8 weeks, but many don't. Fortunately, our ability to predict persistent symptoms is getting better, so we can target the kids most at risk for more intervention. It's important to remember the outcomes of concussion are not just a function of the injury, but importantly are a function of the child who's injured and the family and the community environment in which the injury occurs. It's important to assess pre-injury status as soon as possible after these injuries, because retrospective biases may increase with time, to identify prognostic factors and consider both injury and non-injury factors, and consider using prediction rules like the 5P, because despite our inherent belief that we are good at predicting, it turns out that rules and algorithms are better at it than we are as humans. And prevention and treatment are possible. I'm impressed by the evidence suggesting that psychological interventions for concussion are as powerful as biomedical interventions, but we need a lot more RCTs. I appreciate your attention. I point you to pediatric concussion guidelines if you want the most up-to-date information, particularly the living guideline that was initially funded by the Ontario Neurotrauma Foundation and now lives on a site by itself. This is now a living guideline that's being updated continually and highly recommended, along with the CDC concussion in sport and a Canadian guideline that Parachute has produced. And finally, I'll just close by encouraging all the researchers and clinicians that are in the audience to take a look at the Canadian Concussion Network, consider attending our annual meeting that's going to occur in Montreal in June, just after the meeting of the Canadian Traumatic Brain Injury Research Consortium. Saturday ran over a little bit, but I have to thank all my collaborators, trainees and staff, and agencies that support the work that we all do together as a big team. Thanks very much, and I'd like to entertain any questions I do, given the time.
Thanks very much, Keith. What a fantastic talk, and thanks for all of that really important education about concussion, its mechanisms, what we can do. It's quite heartening, the research that you're engaged in. We are running a little bit late, but you're going to be coming back to the expert panel. So there are a couple of questions for you, but we're going to revisit them at the.
Yeah, I'll type some answers in the panel and let you guys get back on schedule. Sorry for running over there a little bit.
No, not to worry. We really appreciated that talk,